Okay, good evening, or wherever we happen to be, because I think we've got people coming from across the nation and even some people coming internationally. I'm Joe Gallo. I'm with NCCN, and I'd like to welcome you to the first of a series of active surveillance webinars. Tonight we're having Peter Carroll come in as our guest speaker. We'll get more on the intros in a moment. I just want to give you some administrative notes as we go along. Hopefully everybody is familiar with or has seen the video that I sent out on how to use the control panel, which is off to the right. Essentially, the only thing that you're going to really need to be concerned with is being able to enter a question. You can go to the question box and post a question, which will be discussed later on in the after Dr. Carroll's presentation. The other thing is that we will be recording this. There will be a video. The video will be made available for those that would either like to show it again or those that we have some folks who have registered, but like the fellow from Australia was probably not joining us at this time. I think that's pretty much it. You did get in your follow-up also for anybody who is coming in on the phone that the access to Dr. Carroll's slides so that you'll be able to follow along. If you don't have that information immediately available, the easiest thing to do is just go to the NCCN website under events, and you will find that reference right there. And I think that should do it for right now. Let me hand off to Rick Davis from NCCN, and we'll get started.
Good evening, everybody. I'm Rick Davis, as you just found out, and I am the founder of NCCN, and I'm truly honored to welcome all of you out there across the world, across the country, across the world, and especially honored to welcome Dr. Carroll. We would not be here if it were not for some pretty significant people that are attending this webinar. First of all, a huge shout out to Howard Walensky, because it was Howard that came to me about 2 months ago and said to me that he felt that there was a need for an active surveillance series. Howard is one of the flag-waving standard bearers of active surveillance. Many of you have read his articles, and some of you have seen him and participated with him in groups. And we recognize that active surveillance is a very, very significant aspect of prostate cancer treatment at NCCN, and Howard has put together some just outstanding names, starting with Dr. Carroll and moving on to Drs. Helfand, Westphalen, and Dr. Epstein, who many of you know because he's probably read your slides. But I think what Howard didn't really understand is that there is so much more to producing a webinar than getting the speakers. The speakers may be the most important part, but we could not produce this webinar were it not for the amazing volunteers that are bringing this to you tonight. We are all volunteer at NCCN at this point, and our guys have just, and ladies, have stepped forward to the front to be able to allow us to produce and bring you this webinar. The third person I want to acknowledge for us being here tonight is actually Dr. Carroll, because back in 2008, I was privileged enough to sit on Dr. Carroll's Prostate Cancer Patient Advocacy Committee at UCSF. And frankly, if it hadn't been for Peter having faith in a couple of projects that I brought to the committee, I'm not sure that my advocacy career would have taken off in the way that it has. The first was a pet project of my own because I was on hormone therapy at the time, that we needed much, much better assistance and education for men on hormone therapy, and Peter knew that. And we produced a pamphlet at UCSF that has now been read by thousands and has helped many, many, many men. And the other project that we produced at UCSF was to create support for people to exercise whilst they're on treatment. The idea being that we could provide support for diet by referring people to diet counselors, but we never really paid a lot of attention to exercise. And back in 2008, exercise was not seen to be as significant as we know it is today. And Peter, of course, agreed, and we put in place an exercise program allowing exercise consults. From some of that very early advocacy that I did, I started to participate in US2 groups, physical groups, and then we moved on from there and created virtual groups back in 2011, or 10, which was quite a long time before COVID. First of all on the telephone, and then video chat groups using GoToMeeting as far back as 2015. Today, ANCAN has 25, soon to be 28 monthly groups. We address 11 different conditions. We have 9 groups alone just for prostate cancer a month. And 2 of those groups are for active surveillance, and it wouldn't surprise me as a result of this series that we'll soon expand that to a weekly meeting for active surveillance. So I encourage you all to, first of all, attend the 3 upcoming webinars, which you will receive notice of. And secondly, to join our active surveillance group, you can go to ancan.org, which we will make sure is in the chat window, and you can sign up on ancan.org. You can go to the prostate cancer page. You'll read about our active surveillance moderators, who are all going to be asking questions later on tonight, and you can sign up. So enjoy the webinar. I know you will. Peter is extremely erudite, and the information that you will hear from one of the godfathers of active surveillance is going to be very, very helpful to all of you. I will pass on to my co-sponsor in this. I should actually mention that our co-producer, if you like, co-presenter is US2, and this webinar is also being supported by Zero, by PCI, by ASPE. I hope I didn't forget anybody. I think that's right. Oh, PCRI and PCRI. And we are also very, very proud that we've brought this collaboration together. It has not been easy, and we are moving to a point with prostate cancer where I think we are going to see much, much more collaboration. With that, I'll pass you on to Jim Schrade.
Thank you, everybody, for coming tonight. I'm Jim Schrade. I'm honored serving as the chairman of the board of US2 International. US2 is a support, education, and advocacy organization for prostate cancer patients. We have a network of about 200 independent support groups nationwide. We have a website, and we partner with other prostate cancer organizations in presenting programs and sharing information and resources for prostate cancer patients. On behalf of US2, we're very proud to co-sponsor this series of webinars on active surveillance. In my personal view, active surveillance is the most important element in reducing the potential harms of widespread PSA screening and turning back the wave of harmful overtreatment that has ensnared so many of us. Active surveillance needs to be universally available to patients diagnosed with low risk and favorable intermediate risk prostate cancer. In addition, the prostate cancer support, education, and advocacy community needs to work together to increase awareness of active surveillance and identify and address the unique needs of active surveillance patients. This series of webinars is an important part of that process. I want to recognize the great work of Howard and ASPE in bringing this together and in creating in ASPE an organization dedicated solely to active surveillance patients. Finally, in our support groups, we've discovered that active surveillance patients have unique needs and concerns that are probably best addressed in a setting devoted solely to active surveillance patients. For example, in the case of advanced disease, people are really frequently concerned about making life and death decisions about treatment and that kind of thing, where in the case of active surveillance, it's dealing with the anxiety of knowing that you have a disease that you're monitoring and dealing with the ever-changing monitoring recommendations and requirements. In dealing with all this, I want to recognize the work of Rick Davis and ANCAN Foundation in forming and running their great dial-in support groups for active surveillance patients. We're proud to be working with ANCAN and ASPE and our other co-sponsors, and we look forward to participating in the remainder of the series. With that, I'll turn it over to Howard Walensky.
Brief because it's one second here. How's that? All right, I'm going to keep it even shorter now. Thanks to Jim and Rick was right. Getting speakers is one thing. Doing social media is something else, and it's hard work, and we worked with all the partners that Rick mentioned, and we got, we have close to 500 people who signed up, and they're from all over they are from all over the world, from Iceland to Australia, from England to Ecuador. But the real reason that we're here today is to talk about something that we all have in common, an interest in active surveillance. And I've been on active surveillance for 10 years. I originally saw a urologist who wanted to operate on me next Tuesday. And I was lucky enough to get a second opinion and shown some of the research and made a decision and haven't looked back. And so the one thing we have in common as a group is that we're interested in active surveillance. Either we're on it, or we're thinking about it, or we're a spouse or a partner who's helping us make a decision. So that's one thing in common. But the other thing we have in common is the speaker, Dr. Carroll. He, if it wasn't for him, none of us would be here. Not only him, but Dr. Klotz and some of their other colleagues, as Rick said, the godfathers of active surveillance. Our lives would have been different if it wasn't for Dr. Carroll. Now, I'll tell you a little bit about Dr. Carroll, and he'll finally get his chance to take over in a minute. Dr. Carroll, until recently, was chairman of the urology service at UCSF. He developed this active surveillance approach. It was a revolutionary idea, but it was hardly an overnight hit. It involved persuading men with Gleason 6 scores to accept the idea of living with their cancer. And it involved persuading urologists to act against their own financial interests of performing a bread and butter procedure, the radical prostatectomy. Now, Dr. Carroll developed a novel program in clinical management of and research on active surveillance for men with low burden prostate cancer. He's been committed to reducing the burden of prostate cancer treatment physically, psychologically, and monetarily. And his interests include examining the impact of lifestyle on health-related quality of life and survivorship. So I'm going to shut up now, and Dr. Carroll will take over with his presentation.
Well, hopefully you can see me. Rick, Joe, James, and Howard, thank you very much for this wonderful opportunity. We're certainly living in unusual times, but the one silver lining of COVID is we've learned to reach out to patients and providers around the world in a virtual reality, which has been quite good. We shut our ORs down, but quickly UCSF went to online video visits, and I don't think we'll go back. It's allowed me to talk to people in New Delhi, around the country, Europe, and Asia. As our ORs were shut down, it also allowed me to get a lot of work done, research work, and I'll show you some very new data on surveillance, use of MRI, what predicts progression, the risk of metastases, things like that. I'll go ahead and I will share my screen now. Let me do this here. I do this where now? It should be, where do I put, how do I share my screen now? I was doing that before. My webcam I'm sharing.
Joe, can you come in and see if you can help Peter find the right button on his control
Yeah,
panel?
I have everything here, but I don't see that. I think you have to make me, my computer shut down, so I had to go back on. So you have to make me the presenter again.
Again, yep.
Yep.
That's what happened.
Talk for a moment so I can make sure I know which one you are.
Yeah. So
Okay.
hopefully you see me there. Just if you could make me the presenter, we'll go forward here.
Yep.
Someone asked me about the history of active surveillance. Both Laurie Klotz and I trained at Sloan Kettering. He just a little bit before me. And I think you'll be able to see my screen now.
Yes.
Let me do
Yes.
this.
The only problem we have is you're being called Rick Davis, but other than that, you're all right.
Okay, well, that's an honor and pleasure. But both Laurie Klotz and I trained at Sloan Kettering Cancer Center. And our mentor at the time was someone called Willett Whitmore. And I think Willett Whitmore was the first one who started to think about the concept of not treating prostate cancer. And at a small number of patients who he didn't treat, but this resonated both with Laurie and myself. And Laurie, of course, started a bit earlier than I did. And then what really drew me to this was I started to see probably 15 years ago was, given the repeated use of PSA, the widespread use of PSA testing, I got very concerned about the issue of over-detection. And I wrote an editorial called Over-Detection, Over-Treatment, or Both. And I said, I think surgeons will be judged by this, and I think currently we will be judged quite poorly. And that kind of started me on this path. And because I'm a very, very busy surgeon, that's what I do. I came from the operating room today, started around 6:30, and something I do continuously, but I do it in men who I think will benefit from it, not from men who don't. So, surveillance is a response to overdiagnosis and overtreatment. although I think prostate cancer is overtreated, I also think that it's undertreated. So I think men with high risk disease frequently don't get the treatment they should get. The information I will share with you is largely my own perspective developed in a big cohort at UCSF. And even though I'll show you some slides I use in medical presentations, I'm going to walk you through them. And hopefully you'll find this of value. So I want to go here. So active surveillance is response to overdetection and treatment of prostate cancer brought about by widespread and repeated PSA testing. The uptake of surveillance by the urologic community helped pave the way to an upgraded assessment by the U.S. Preventive Task Force on the early detection of prostate cancer. If you remember, in 2012, the U.S. Preventive Task Force gave prostate cancer grade D recommendation for screening. That means don't screen. And this actually had adverse effects. So we saw the rates of screening go down. We started to see higher risk disease, a lot of controversy, but this was reassessed more recently based on a reassessment of the data and the fact that I pointed out to them that urologists are no longer overtreating prostate cancer. I'll show you some data suggests that many still are, but in fact, the uptake of surveillance is rather dramatic. Let me see if I can go forward here. So the goals of surveillance are to avoid or delay the cost, functional and monetary, of treatment without compromising cancer cure. It's compliant with screening guidelines in Europe and in the United States. It's based on the rationale that initial assessment is reasonably accurate, monitoring is accurate, and identifies subclinical progression at a time that the initial treatment options are still available and curative. Surveillance is about timing of treatment. It's not treat or no treat, it's about timing of treatment. I will show you how often men on surveillance get treated. But I tell people it's about timing of treatment. If you can avoid treatment for 10 years and still treat that patient for cure, you've avoided the side effects of treatment for these 10 years. Prostate cancer is a spectrum of disease. Now, one thing I think is important to all of you there is when you get a diagnosis of prostate cancer, your physician and others often have to make an assessment about describe your cancer. And we have these terms: very low risk, favorable intermediate risk, unfavorable intermediate risk, or high risk. Something we've developed at UCSF, which I think will be important for all of you, is something called the UCSF CAPRA score. This is a 10-point score developed at UCSF by Matt Cooperberg, myself, and others. And what you do is you simply look at PSA levels, cancer grade, primary and secondary, T stage, the anatomical extent, the number of positive biopsies, age. And this is a sum of 0 through 10. This has been validated around the world. And it predicts for cancer recurrence rates after surgery or radiation therapy. It actually predicts for prostate cancer survival and overall survival. So I think all of you right now, if you're trying to determine if active surveillance is right for you, these are the things you need to consider. Your PSA, and I'm going to go over this again, and I will allude to these during the talk. One is your total PSA, but more importantly than your total PSA is something called PSA density. You take the PSA score and you divide it by the prostate gland volume measured either by MRI or ultrasound. You want a PSA density less than 0.15, hopefully 0.1 or less. We have done many studies showing, we and others, but we were into this early on, that a PSA density, a simple calculation, is a very strong predictor of the risk of progression on surveillance. T stage is your cancer confined to the prostate. Whether it's visible or not, as long as it's confined to the prostate, you may be a candidate for surveillance. Cancer grade, generally surveillance is thought to be applicable to men with low-grade disease. We call it Gleason 3 disease. However, it turns out that some men with intermediate risk disease, 3-4, which are of low volume, and I'll show you something else, subtype, may be also candidates for surveillance. In my opinion, MRI is an important component of surveillance. If men have not had an MRI before biopsy, had a standard biopsy, I think they should get an MRI before considering surveillance. A PIRADS score is a score assigned to an MRI, and what you're doing there is simply assigning a value which shows how abnormal the prostate looks. So a PIRADS score of 1 or 2 is consistent with normal prostate. A 3 is kind of indeterminate. A 4 or 5, again, this is 0 through 5, 1 through 5 scale. A 4 or 5 is associated with higher risk disease. Something we've explored a lot here at UCSF is these gene expression profile measurements, and there are actually now 3 commercial entities, Prolaris, Oncotype DX, or Decipher. We commonly use those, and like MRI, we think they predict for patients who are more likely to progress or actually have higher risk disease at time of diagnosis. And of course, what you always have to look at, prostate cancer is a patient preference cancer. That is your age and health, your individual preferences, both your patient, but both you as a patient and your family preferences, and what kind of confidence do you have in your providers? Again, surveillance is best done by experienced people who put the time and effort to understanding what this really means. So I'm showing you data now. We actually have about 2,300 men on surveillance. The year of diagnosis, the median was 2010, so that means the average has been about 10 years. The average diagnosis is around 62.5 years. Actually, at UCSF, we've actually enrolled a younger cohort. Many people think that surveillance is only applicable to men who are older or who have other diseases. We'll show you actually surveillance is applicable to younger patients. These generally are lower risk patients, and PSA of 5.5. About 85% of our patients are kind of low risk, Gleason 3-3, but about 15 to 20% of patients are considered higher risk disease based on, usually based on cancer grade. Now, this is what I'm showing you here is something called a Kaplan-Meier curve. I'm showing you here the percent of men on surveillance here and the years along this axis right here. And what I'm showing you here is what I call upgrade-free survival. What's the likelihood of men not having any upgrade at 7 years? So at 7 years out, about 41% of patients who've undergone serial imaging, serial PSA biopsy will not have any change in prostate cancer volume or grade. Now, if you look actually at treatment-free survival, it's much better. So 59% of patients are still on surveillance at 7 years. And the reason for this is many changes that you see on cancer grade and volume are lower marginal. So actually, if we see small changes, small to moderate changes in volume, small changes in grade, especially a change from a 3-3 to a 3-4, low volume 3-4, many of these patients stay on surveillance. In general, we see little difference between 3-3 and 3-4, but I'm going to get back to you on this because I will show you based on volume, patients with 3-4 disease do have a higher risk of progression over time. So the overall survival has been 96%, prostate cancer specific survival is 99%, metastases-free survival has been 99%. We have identified a small number of men who've developed metastases. The vast majority of these have been regional lymph node metastases. The risk of metastases in bone, liver, lung is really minuscule. So, many men ask me, well, look, if I go on surveillance and I progress, what can I expect? And I can tell you what my experience has been when men progress on surveillance, the overwhelming vast majority of men get treated the same way that they would have been treated with to begin with. So men really don't lose options to any significant degree. But if you look at men, I think I have the largest experience of men who've been on surveillance and went to surgery. Now, this is about 450, 460 patients. Now, remember, this is a small cohort of the overall. I told you there were 2,300 on surveillance. I've operated on about 500 of them. So the rest are doing fine. About 45% of these patients will have something what I call adverse pathology. That means when I remove their prostate, they had disease going outside the prostate or higher grade disease. The overall prostate cancer specific survival has been excellent. So if you look at these men, even though the men that have operated on are higher risk, and you see that if you operated on men with 3-3 disease to begin with. But even with that, the majority are cured and do not have detectable PSAs. Now, I think one thing that's made surveillance more acceptable, the major anxiety among men and physicians who treat them is the thought that they that you missed kind of the higher grade or higher volume disease, that you only got the tip of the iceberg. This is a major barrier to many men and their physicians, is that they're unsure that the biopsy has been accurate. So I'm going to show you here the impact of new technology. Now, if you look at the National Comprehensive Cancer Network guidelines for genomic testing, they recommend doing it on something called low and intermediate risk patients. Again, these are organ-confined lesions, grade 1 or 2, with a relatively low PSA cut point. Very low risk patients are those who only have grade group 1, 3, 3, a favorable PSA density, and very low volume disease. Those patients probably don't benefit as much by genomic testing, but I think the patients with low and intermediate risk disease do benefit. There are many assays. You can go online and look at these. The most common ones are Decipher, Oncotype, and Prolaris. I have no strong feelings about one versus another. I think they generally correlate with one another. I generally think they perform, there are subtle differences between them. All these assays have prognostic value. That means they tell you how you'll do over time. Right now, we're trying to develop a suite of markers which we want them to have predictive value. That means they can tell you, do you get surgery, do you get radiation, or do surveillance alone? These are prognostic markers. They're kind of blind to how you'll be treated. I'm going to just show you one example here. I could show you an example of any one of these commercial assays. Again, I don't feel that one performs better than another, but this is the Oncotype DX. What's remarkable about this assay, as the other ones are, that you're looking at gene expression here, and you can get a reading from about 1 or 2 millimeters of tissue. So you can take 1 or 2 millimeters of tissue from the biopsy that's already been done. This is embedded in paraffin, and you can look at it. You can look to see how it expresses certain genes, and how it expresses certain genes gives you additional information compared to cancer grade or volume alone. One thing that's very important here is if you look at this GPS score from low to high, high is worse compared to low, it generally doesn't correlate with either CAPRA score or grade. Now that's very important because it's telling you that this marker may be giving you information which is unique. If you had a marker that simply predicted grade, it would not be of any value because you already know the cancer grade. But this marker seems to predict, as I'll show you, more than that. Now, we validated the Oncotype DX. Again, we've worked with each one of these assays, and again, I think they all perform well. But what I'm showing you here is, when I told you before, this worry about you're missing something significant. So it turns out at UCSF, over many years ago, I established a large, thousands of a biobank. And so these are men who underwent surgery, and I saved their biopsies and their tissue in a big bank. And those were linked to patient outcomes. So now if a new marker comes, I don't have to start all over again. I can go back to this bank and I can see how things did. And so we asked the question here, if you looked at the GPS score, the Oncotype score, and the biopsy, how well did it predict that when you went ahead and removed the prostate, you had either favorable or unfavorable disease? Again, all these men were candidates for surveillance on biopsy. They all underwent surgery. And we asked the question, could the biopsy predict outcome? And what I'm showing you here is CAPRA score, the likelihood of favorable pathology. That means organ confined, low grade disease. Low CAPRA score, using CAPRA score alone, again, that's PSA, T stage, number of positive biopsies, 86%, go down to CAPRA 4, kind of intermediate risk, it's 43%. But if you add each strata, the Oncotype score, you'll see what you do here is you'll further substratify the patient. So in any single cohort, you'll make patients either more favorable or less favorable candidates for surveillance. What this is telling us is these gene expression assays are giving information that additive to what you already know. And it moves patients both ways. Now this is a slide, it's a statistical slide. And what we're saying here is when you test a new marker, you want to know whether or not it gives you any additional information. So we do something called a multivariable model. We put everything into the model, patient age, cancer volume, stage, and then we want to see whether or not the marker of choice, whether it's MRI or GPS score, adds additional information. And a p-value of less than 0.05 is thought to be statistical significance. That means it's adding information of value. So the GPS score actually predict upgrade on surveillance. So in our surveillance cohort, when we look at GPS scores and biopsies, they actually do predict upgrading over time. Also, again, in a similar model, I'm showing you that actually GPS scores predict both adverse pathology if you remove that prostate, and may predict PSA relapse. So again, I'm controlling for everything else here: PSA density, Kappa score, age, but just showing you that these markers in our cohort, which is a little higher risk cohort compared to others, appear to have value. Now, this is a very important slide that I go over with my patients. Now, even though I show you things like PSA density, Kappa score, MRI can predict upgrading over time, there is no single GPS score that completely excludes or predicts for progression. So you generally don't make decisions on these this information alone. What you do is you put all the information together and then you make a decision. But this is not a yes or no. It's actually giving you a measure of risk. We have some people with very high GPS scores don't progress, and we have some with low. Upgrading here is blue, and we have some down here with very low scores who actually upgrade. But again, as you increase the score, you're more likely to show upgrading over time. Concerns, we worry about genomic, tumor heterogeneity. It turns out that's less of an issue because when you take a biopsy from one part of the prostate and do gene expression profiling compared to another, they generally correlate. Which patients are they cost effective with the long-term outcomes? These are questions we're answering at UCSF and a few other places, but not as many as I would like. Are the other biomarkers? Well, again, the one I told you, which is easy to get, I'm always surprised that this is not used more often, is PSA density. Again, a PSA density below 0.15 is favorable. 0.1 is even more favorable. If you have a PSA density, again, PSA density is PSA divided by the gland volume. Greater than 0.15, these patients have a significantly higher risk of progression. The hazard ratio is a factor of 2. That's my phone going off. But about 2 times more likely to have biopsy progression. A negative biopsy. Now, I apologize, this is so light here, but what I'm showing you here, and when you look at men on serial biopsy, about 20% of the time, if you look at a cohort of men undergoing biopsy, about 20% of the biopsies are negative. And again, you predict this, but a negative biopsy, 1 or 2 are strong predictors of non-progression. So if you're on surveillance, you have a negative biopsy at any point in time, you are less likely to progress compared to those that have persistently positive biopsies. What about MRI? MRI, the world's been taken by MRI. I'm going to show you some strengths and limitations. It does turn out that a PIRADS 4 or 5 does predict for progression. If you put it into a model that includes genomic scores, sometimes that falls out. So they both predict for progression. But we've actually looked at this. Changes in MRI are very common. If you have a PIRADS 4 or 5, or any increase in PIRADS over time, that's going from a 3 to a 4, that predicts for progression. So any PIRADS 4 or 5, or MRI which shows changes over time, those are men most likely to progress. So again, I'm just showing you the genomic scores and MRI are helpful. Current controversies are like, who do you do this on? Only very low risk patients, low risk, maybe those with Gleason 3-4 disease, African-American men, and what about younger men? The younger men thing is quite interesting because I was in a lecture at Hopkins and someone asked the Hopkins group about doing surveillance on younger men, and their cohort men are much older, but it turns out at UCSF, about half of our patients are below the age of 60. And we looked at upgrade-free survival rates over time, and it turns out that younger men have a lower rate of upgrading compared to older patients. And we actually kind of knew this because it turns out that older men have worse cancers than younger patients. And we saw no association between age, time to treatment, or any adverse outcome from surgery. I see a lot of men who are young, many who have not completed their families, who got a biopsy done by serendipity. By that I mean their PSA was high, got a biopsy, showed low-grade disease, another PSA is normal again. Men want to go biopsy with a normal PSA but have an abnormal digital rectal examination on one side, found to have cancer in the other. So what I'm showing you here is that I think younger men have an opportunity to consider surveillance as well. Now, obviously, if you're younger, if you look over time, you're more likely over the next 30 to 40 years to progress compared to a man in their 80s or 90s, but that appears to be a safe option. And this has been published, and we continue to see this. Special situations, it turns out germline mutations. So for men with advanced disease, we see that at least 12 to 15% may carry these germline mutations. We get germline testing, that means testing your DNA, buccal swab, and men with a strong family history, certainly first degree relatives, early age, lethal disease, any men with intraductal disease. It's thought that men who carry a BRCA2 mutation may have worse cancers and may not be great candidates for surveillance. African American men are more likely to get prostate cancer, they tend to get worse cancers and may fail. But we're part of something called the Canary Consortium, and when we looked at African American men compared to Caucasian men, there was no difference in reclassification over time. But I always point out that even though I think you should not make decisions based on ethnicity alone, it turns out that men of color make up a small number of the total population of men on surveillance cohorts, even our own. So it stills the word out. The word's out there on this, but I don't think that they should not be denied active surveillance. I do think these are patients who would benefit from the use of advanced technology like MRI and oncotype testing or like this. If you look at treatment-free survival after surveillance, it turns out those with 3-4 disease have a higher likelihood of progression compared to 3-3 disease. When we look at, my mouse is acting up here. When we look at PSA-free survival, so UCSF, we set the bar very high for recurrence. So I'm showing you here is any detectable PSA or any second treatment. So again, about 12 to 15% of men followed over time who underwent delayed surgery will have either a detectable PSA or require second treatment. That means they may have been treated even though the PSA did not become detectable, usually based on adverse pathology at the time. You see figures like this for men who were treated right away. So I don't think there's much difference. When we look at recurrence for 3-4 disease, it really looks like grade alone is not the driver, but really volume. So if you have a small volume 3-4 secondary pattern 4, you may be a candidate for surveillance. I think a larger volume, you're not a great candidate for it. Another important thing that we've recognized, and around the world people are recognizing, that if you look at the Gleason pattern 4, Gleason grade 4 disease, it turns out there are different histologic subtypes. These subtypes are visible to the pathologist, but unfortunately very rarely commented on. And we advocate strongly for this because we have shown that so-called cribriform histology and stromal reaction are associated with a higher genomic scores, a higher risk of extracapsular extension and recurrence compared to glomerulation and no stromal reaction. So I advise all men with Gleason 3-4 disease, consider having your slides re-reviewed, but importantly, ask your pathologist, what's the histologic subtype of the pattern 4? Okay, this is, I can't show you all the work we've done here, but I'm showing you a single slide which shows what predicts for upgrade over time. And again, when I show you these things in red here, doesn't mean that everyone with those will progress, but these have a higher risk compared to those with lower risk features. It turns out, interestingly enough, that men over the age of 65 have a higher risk of upgrading over time compared to men who are younger. Again, totally counterintuitive, but we've just finished this study. So older patients actually have a higher risk of upgrade. Not all of them upgrade, but they have a higher risk compared to men below the age of 65 or 60. PSA density greater than 0.15 predicts upgrade. A high GPS or high genomic score You can pick out, the average GPS score is 20 or 22, so 30 is high, but you can look whether it's Polaris or Decipher. A high Decipher, Polaris, or GPS score should be interpreted with caution. PIRADS 4 or 5 are associated, an MRI is associated with higher risk of progression, and higher volume Gleason 3-4 disease. It turns out that a UCSF biopsy is also predictive. It's interesting when we have found that we compare our patients who've been diagnosed with low risk disease at UCSF compared to those people we see who've been diagnosed elsewhere and come to us to follow up over time, that a UCSF biopsy is protective, just showing you that a well-performed biopsy is important. I think it's really due to Katsuda Shinohara, who I work with for a number of years, who's outstanding in this regard. We're hopeful that MRI before biopsy will level this playing field about who does your biopsy. Risk of metastases, again, 1%, 70% of these were in pelvic lymph nodes. It turns out the volume of Gleason grade group 2 disease actually was the predictor on this. So again, be cautious. For those who have high PIRADS scores, high PSA velocity, PSA is going up, larger volume Gleason grade 2 disease, these are patients who are at higher risk. Even though only 1% of the cohort, or less than 1%, had metastases, these were the predictors of it. Now, one thing we're trying to do is make surveillance less burdensome. This idea that you get an MRI every year or a biopsy every year is way too burdensome. And so what we looked at recently was what predicts for upgrading early on. I mean, what predicts? And again, it was PSA density, number of cores positive, and the genomic score. The PIRADS score was not significant only because the genomic score was in the model. But again, high PSA density, large volume disease, high genomic scores, high MRI, these are patients who should be biopsied between 12 and 18 months. But those patients who have favorable genomic scores, low PSA density, low volume disease, they have a lower risk of reclassification. PSA actually is not very predictive early on. PSA tends to be quite stable early on, but it does predict in the out years. So actually PSA predicts in the out years. And so I think PSA is a marker of true biologic progression. So you need to do it. So, but we think this will lead to a more refined approach. So again, if your patient comes in, sees me, and they're talking about surveillance, if I see high volume disease, adverse genomics, PIRADS 4 or 5, cribiform histology, these are men I think you either treat or do an early confirmatory biopsy. Men with low PSA density, favorable MRI or genomics, these are men I would generally biopsy at 12 to 18 months. Obviously, men who are in poor health should be followed in something called watchful waiting. You're just looking for symptoms. Now, one thing we're doing at UCSF, which we feel excited about, is we'd like to get out of the biopsy business. So we're actually identifying and working to validate markers of progression in the serum and urine, obviating the need for biopsy. So stay tuned on this. This is a project we're starting this year, but we think we might be able to follow these tumors genetically by analyzing things in the serum or urine. And I think that would make surveillance very easy for patients. This is our cohort at UCSF. Toronto is the other big cohort. Johns Hopkins. Prius is a worldwide, is a European cohort. We're actually a part of a large international consortium with them, and Canary Path is another cohort where we partner with, and just shows you that the outcomes are all very similar. So these are the big cohorts worldwide and very similar. About 1/3 of patients progress at 5 years, 50% by 10 years. The risk of metastases or death through disease is actually quite low. A little higher in the Toronto cohort. They had a little higher risk cohort, didn't use as much technology as we do, but again, favorable outcomes. Now, what about surveillance? I've told you it's been looked at by all international guidelines recommended. And what I'm showing you here is a chart looking at red is surveillance, blue is surgery, green here is radiation therapy. Let me go back there. And this is what I'm showing you here around the US, Atlanta over here, Utah, and you can see considerable variation in the use of these and use of surveillance. Again, these are all low-risk patients. The highest rates of surveillance, I'm proud to say, are in the San Francisco Bay Area. But you go in parts of the country, Georgia, Hawaii, New Mexico, very low rates of surveillance in favorable patients. We think this variation is disturbing to us. When we see this, we want to understand why it is, and we think there needs to be more uniformity. But again, on the West Coast, more surveillance compared to other parts of the U.S. So this is disturbing to us. What can you do? What I tell patients, don't rush. It is rare that a patient with prostate cancer has to rush to treatment. If you ask a patient at 12 months after their diagnosis what they would do differently, the number one thing that they mention is they would not have rushed to get treated. So very rarely do you need to rush. And actually, we have good evidence that actually for men with localized disease, whether you get treated at 6 or 12 months may make little difference. This has become important, of course, in the COVID era. But don't rush, get informed, understand the impact of new technology, consider a support group, understand the impact of a healthy lifestyle, diet and exercise. You can go to our website. We've actually been funded by the, as Rick mentioned, people like Rick really pushed us to do this. Understand the impact of a lifestyle and diet and outcome. We've worked with Dean Ornish on this. I think both the Prostate Cancer Foundation and UCSF have put together some very nice files on a dietary approach, which I think is very doable. I think it's at least complementary, and we've shown that men who adopt a lifestyle approach, diet and exercise, may reduce their risk of progression on these are low-risk patients on surveillance. And actually, we have population-based data that suggests that men who adopt a healthy lifestyle may reduce their risk of recurrence after standard treatment. So again, is active surveillance right for you? Again, think about your PSA density, the stage, cancer grade. If you have a grade 3-4 disease, understand the volume, what's the subtype. I think MRI is standard now. I mean, if you get diagnosed with low-risk disease, I think at the very least you should have an MRI. I usually recommend genomics as well, but I think MRI is standard because an MRI looks at your prostate to see if you've missed higher risk disease on the initial biopsy, and of course is a template for we call it fusion guided biopsy. MRI can't be used alone, so if you got to be cautious. You want to use MRI. The negative predictive value of a normal MRI. So if you get a normal MRI, you still have about an 8 to 15% chance you could have high risk disease. So when we look at MRI, we look in the context of PSA density and other markers. Again, your age, health, patient family preferences, what's right for you. Do you have confidence in your providers? If you don't, you should try and negotiate that or find someone else. And do you need a confirmatory biopsy? So it's usually men on surveillance will need another biopsy. As I showed you, when you look at MRI, genomic profiling, cancer volume and grade, you can determine whether you should undergo what I call immediate confirmatory biopsy within 6 months, or you can wait 12 to 18 to 24 months. New developments, I just want to end on this. You know, one thing that's happening is nowadays we're trying to reduce the likelihood that low-risk patients are diagnosed. And what happens now is, and you can go to the NCCN website, I lead the NCCN early detection panel, and for men who've had a PSA that's elevated, confirmed to be elevated, that you can go to a biopsy, but in fact what you can consider is secondary markers of specificity. What I mean by that is these are markers which tell you, well, if you have an elevated PSA, what's the likelihood that you have high risk disease? And the 4K prostate health index, exosome DX, these are serum and urine markers. Multiparametric MRI performs in a similar fashion. Using we've been able to reduce biopsy rates 27 to 40% here at UCSF. The other interesting thing we've looked at is this issue of focal therapy. I was lecturing in China, and a well-known urologist says, well, Dr. Carroll, surveillance may be fine in a country like the US, which has resources, but here in China, one, men who diagnosed with cancer won't accept surveillance, and two, we have many men coming from remote distances who don't have access to an MRI urologist. So surveillance can be burdensome for some patients, may not be practical for some patients. And the issue, of course, is are these patients candidates for something rather than radiation or surgery? And the issue is focal therapy. There's a big interest now in using focal therapy in lieu of surveillance. And we've looked at our surveillance cohort at UCSF recently, and this is submitted for review. But it turns out that based on 2 biopsies, so you get your first biopsy, confirmatory biopsy, about 63% of patients may be candidates for focal therapy, either initially or over time. So we think some men on progression may not need to undergo surgery, may not need to undergo radiation, but may be candidates for focal therapy. And of course, you need a well-performed biopsy, experienced provider to consider this. So in summary, I think active surveillance is a preferred form of treatment for men with very low, and selected patients with favorable intermediate-risk disease. I think technology, MRI, genomics appears to make it safer. Its use remains highly variable, and I do think going forward it may be challenged by new forms of focal therapy. Obviously, I'm giving you a lot of information here. This is based on work done at UCSF. I work with a wonderful group of people, too numerous to mention, but my career has been made much more productive by being in a place like UCSF, and my colleagues have contributed to this. So thank you very much. And I'll stop sharing my screen, but I think someone else is going to go over here.
I think Howard's coming in next.
Thank you. Howard, are you with us?
Can you hear me?
We can.
Yes, go ahead. Yep.
All right. Well,
Turn
Peter
your
assumed that the
Your webcam on as well.
audience is applauding raucously, and everybody's very pleased with what you said. We're gonna ask some questions. Two of my colleagues are going to be coming on as well, I think. Mark Lichty and I'm having one of those days, and Elliot Herman. But at any rate, I had some questions for you to begin with. Back in the day when you were developing active surveillance, how was the idea received by patients, and how was it received by your bosses?
Well, you know, luckily I became chair of this department at a very young age, which has not done much anymore. I've been chair for 24 years and actually decided to step down. So we had built a big reputation to begin with. So we had data, and UCSF is the #1 research program in the country. We have more NIH funding than anyone else. So when we showed data, we backed it up with real world data. So we didn't just go out there and make a hypothesis. We based it on the knowledge we had to date, and we integrate technology quite carefully. And I think we had a reputation for doing the right thing. So I didn't face, I was in. Some people say they don't believe in surveillance, but actually, the more we studied it and the more we studied it well, I think we met less resistance. The big resistance what I have found is that many men before biopsy are never told about the issue of overdetection. So what I tell people, if you want to make, many patients come into my office, and many high-profile patients come in to see me, many very high-profile patients wanting to get surgery, and I tell them I don't think they need it. And they're shocked because no one's ever talked to them about that before. So I advise physicians before they do a biopsy, you got to tell patients the goal of the biopsy is to identify disease which puts you at risk, but I may find cancer and I'm going to tell you not to do anything. So you need to get that out even before the biopsy. If you make a diagnosis of cancer, a patient doesn't understand that the surveillance is an option, it becomes more troublesome. I think people get it now. I think they just don't practice it as well as they should.
Now, I had read that maybe 6 to 10% of men who were candidates for active surveillance 10 years ago decided to go that route. And now I believe it's over 50%.
Correct. It
And
should
I
be
wonder,
more.
okay, that's where I'm going.
Yeah.
What's the problem?
Well, the problem is I don't think everyone subscribes to it, either patients or physicians. And it's just not urologists. I mean, I think, people who used to, either because by their training or their background are used to doing something. And of course, patients, unless you spend some time talking to them about the data, may be inclined to be treated. So most patients, when they get the diagnosis of cancer, they think, we did some group, I think this was when Rick was around, we did some work early on for men with prostate cancer, and we found that most men with prostate cancer, when they got the diagnosis, they thought this was a cancer like pancreatic or lung cancer. So they thought that without treatment, they would lose 15 or 20 years off their life. But what it took was good data. So we can show, I can give men the actual data. So as I told the reporter the other day, we know there are some patients, we see some men with a strong family history and adverse outcome and a relative who choose treatment. But I told the reporter the other day, I'm completely comfortable with decisions men make, but they just need to make it on the best information available to them. And unfortunately nowadays, I don't think all men get that information. So if men get great information, they're candidate for surveillance, still want to be treated, it's a free country. I'm comfortable with that. I think you're muted.
Howard, you're muted. Well, maybe Peter, while we're waiting for Howard to come back, maybe I should continue with some questions just so we don't have dead air time and 500 people sitting waiting for questions. So I can't, this is outstanding what you're doing. I've been on active surveillance for 15 years, and this is the work you're doing is so critical in reducing anxiety amongst men. By the way, Howard, if you get unmuted and want to cut me off, just cut me off. I'm just trying to keep this thing going. So the work you're doing is so critical in helping men deal with anxiety. There is way too much anxiety around this illness. And 15 years ago, I spent a year or two just not knowing how this disease was going to evolve. And today we don't need to go. Men that are on this call don't need to go through that level of anxiety. So I want to thank you for that work that you're doing. One of the questions that I saw in the question window was that people wanted to know where they can find a urologist proficient in active surveillance. How do they do that?
Well, I think what I'd like them to do is to take the notes on some of those slides that I showed about what information I think they need to have. So I think they need to get educated and they need to talk to the urologist. Now, I think technology is kind of leveling the playing field here. So I think you want a urologist that's open-minded, that will consider surveillance. I think if you have a urologist that doesn't consider surveillance, I don't think you can make them. But I think community-based urologists are generally very well trained. I do see sometimes a reluctance to use new technology like MRI, genomics, but I think patients need to do their homework. Nowadays you can get information, meet with your urologist, talk to he or she about this option, get their experience with it. How they do it, why do they do it that way? I think whether you're talking about surveillance or even surgery or radiation, I think in this country you can buy a loaf of bread with more transparency than healthcare. So no matter whatever you're talking to your urologist about, you want to understand what their experience has been, how do they know what their experience has been, and for men like me, what can I expect in their hands? But I think around the country now, this is not as much of a concept that you can find patients. Now, the other thing I want to point out is with Zoom visits. So man, the world's gone to Zoom. So 80% of my practice is on Zoom. Nowadays, you can get your insurance to allow you to see a practitioner almost anywhere in the world. Like, I don't know about in Europe or Asia, but in the US here, you can reach out to people for an opinion. And so we've been able to direct people across the nation on things to consider. So nowadays with new technology, most you can actually connect remotely to high volume centers.
Thank you for that. Howard, are you unmuted now? I'm going to pass this back to you. I was just trying to fill in.
Yeah, I appreciate that. Can you hear me now?
We
Yes,
can.
we can.
Okay, sorry about that. Peter, of the population of men on active surveillance, what percentage will drop out over time and why? And what percentage will stick with it for the long run?
Yeah. So we have found that about 6 to 10% of patients will drop out in the absence of progression. Now, that's why we're trying to make surveillance less burdensome. I think sometimes people get anxious, but some people just get tired of the burden. So we think that by using new technology, we can make surveillance less burdensome, reduce the need for repeated biopsy. We think that number will go down. The other thing is good information. So you can decrease a patient's anxiety a lot if you give them good information. If they feel they have a trusted source, you can show the data, then surveillance. You know, people's anxieties go down when they're well informed, when they see the future in realistic terms. And so I think 1, good information. 2, we need to reduce the burden of surveillance.
But what percentage stick with the program for the duration? Is this?
So people stick with it. So UCSF only 6 to 10%. So 2 ways to get out of surveillance. 1 is to progress. So they told you 1 in 3 men at 5 years gets treated, maybe 50% by 10 years. So they progress. What I'm saying is that 6 to 10% of patients may opt out of surveillance even though they haven't progressed. So again, at 10 years, half the men will be on surveillance, half will not.
You know, one of the encouraging things that you said was about the serum and the urine maybe eventually taking place of the biopsy.
Correct.
If you've ever gone to a support group for men on active surveillance, you would pick up on how much men hate these biopsies.
Correct.
You probably know.
Yeah, but we've, you know, the past predicts the future. So how you've done in the past predicts how you're likely to do in the future. So you can actually reduce the burden of biopsies fairly significantly. And if you look at those Kaplan-Meier curves, the curves decline early and then start to level out. And the reason for that is the initial biopsy just missed something. But actually that curve flattens. So with knowledge, you can reduce biopsies frequency considerably over time. But again, we like to get rid of it.
Elliot, why don't you dive in?
Yeah, Dr. Carroll, I had a question about what you were talking about the histopathological subtype. Should pathologists typically report that on biopsy reports so we would?
In my opinion, yes, because this is freely available. You don't have to pay anything extra for it. This is on the slides. Now, the only issue is there may be concern among pathologists about how to read this versus that. But I think this will become a standard part of every biopsy report. I'm starting to see it in some high volume centers that didn't report it before. I'm starting to see it on that. We report it routinely. But I think if you have a Gleason 3/4 cancer, you need to ask your pathologist, I'd like to understand the histologic subtype, cribriform, glomerulation, expansile cribriform. That gets us going introductal. So I think with time, this will be standard. It's not yet. I think it's got to get out there more. I think pathologists and community have to understand how to read these slides. But again, it costs nothing. It's there. And so we think it should be routinely reported.
Just to follow up, do you think that that's something that the community, we should be advocating for in some way?
Yeah, when I see people in consultation, I say that we can get your slides and review them for you, but why don't you ask your pathologist, what's the histologic subtype of the pattern 4? And in that slide I showed, I have references for that. And I think they should be able to provide it for you.
Thank you.
Something I'd like to ask.
Go ahead.
We've had a couple of questions about whether, what your views are on spontaneous remission of.
Perfect question. So we have So Howard, it may have been an email you sent. So this came up online, and one of my patients forwarded it to me about spontaneous resolution, and it got my attention right away. So we actually went back, because we have 2,300 men so under serial biopsies, and the title of our paper when we submitted it was does prostate cancer vanish or simply hide? And the answer is it simply hides. So these are usually low volume cancers. So a negative biopsy is relatively common. About 20% of all biopsies are negative. But we've had patients who've had, negative, negative, positive. So my sense is what this tells us is these cancers are probably not resolving, but they're just small. But we've rarely seen people persistently negative biopsies. But I think it may have been from your website, but one of my patients got hold of that. So we actually wrote this, does prostate cancer vanish or simply hide? It tends to hide.
So do I get a footnote then?
You should have. If you probably, so this patient of mine has actually put his name on the paper. So you reached out to me, we would have done it. But we had this, 23-month serial biopsy. We actually looked at it. But a negative biopsy is a strong predictor of non-progression. So again, I'm not saying your cancer has vanished, but if you've had a negative biopsy, you're less likely to progress.
Well, Dr. Klotz has talked about this as well, and he has suggested that it could be spontaneous remission.
I don't think, it could be. Look, when you do biopsies, you get an immune reaction. It could be. I think it's more likely that it's just small in volume, which is fine.
Yeah. Now, do you think the day will come? Well, you mentioned the focal therapy, and we know there's research on, I guess, a vaccine, right? So
correct. So we're looking at an injectable vaccine because the prostate, for human cancer, the prostate's very accessible, very accessible. So we actually have our sights on a tailor-made cocktail that will inject into the primary tumor. Now, of course, in order to do that, you have to go through a rigorous testing of these vaccines in men with advanced disease for safety. So this is a long path, but we have our eye on it. We have developed animal models, PDX models, and now we're developing new cell culture techniques where we'll be doing this as proof of concept. But yeah, I do think that we'll be able to do something for localized disease in that fashion.
Well, and is there some irony in the fact that you've spent so many years working on an approach to monitor and not treat, and then suddenly maybe there'll be treatment? I mean, how do you think that will go over in the patient population? Well, people.
Well, anything we can do for patients will go over well. I was trained as I can do surgery on kidneys, bladder. So we find a cure for prostate cancer, I still have a job. And again, I'm a very busy surgeon. I'm just operating on men who benefit by it. And we're developing new technology for men with advanced disease. So I think we'll always be operating men with prostate cancer. We'll just be operating on men who will benefit, not men who will not.
So Mark?
So yes, I wanted to ask about the liquid biopsy. That seems to be gaining some traction. Some folks are saying that you get the PSA, then you should request a liquid biopsy for stratification purposes, and maybe with a liquid biopsy, you could avoid an actual biopsy. Is there any truth to that?
Yeah, what these are tests. Now, there are two scenarios. One are using for men with an elevated PSA, get an elevated PSA, and you confirm it. So if you get an elevated PSA, the first thing you do is confirm you actually have an elevated PSA. If you have an elevated PSA, you can go right to a biopsy. And randomized trials show that a biopsy with an elevated PSA reduces the risk of dying of prostate cancer. But we think that another alternative in those men is for those men who want more knowledge about their risk, want to avoid unnecessary biopsy, you can do these other markers. Now, they're both serum and urine. Now, these are usually isoforms of PSA. And what they're saying is that For men who have an abnormal value, that they're more likely to have Gleason 3-4 disease. So again, using MRI or these 4K prostate health index, if you go to the NCCN website for prostate cancer, we have all these listed, that you reduce biopsies about 27 to 40%. So you'll avoid biopsying a substantial number of men. If you take 1,000 US men, 250 will have an elevated PSA. About those 250 with elevated PSA, and you biopsy them, about half don't have cancer. The other half who have cancer, about 40% have low risk disease. So what you like, the men who didn't have cancer didn't benefit, and we think the men with low risk disease are put at risk for unnecessary treatment or anxiety. So we'd like to only diagnose the men who have Gleason 3-4 higher disease. Now it turns out that it is true that you reduce biopsy rates 30 to 40%, but you still diagnose men with low risk disease. So in our cohort, even though we're reducing biopsy rates substantially, about a third of the men that get the biopsy still have low grade disease. So again, we have this discussion with them, we reduce unnecessary biopsies, but we also tell them that we may identify low volume disease. These may not work as well on surveillance, however. So if you have a diagnosis of cancer, I think these markers don't work as well. Now the markers we're talking about are markers that reflect the genetics or the biology of the tumor itself. Not whether you have cancer or not, but actually of what's your cancer like. So that's, liquid biopsies have a kind of a checkered history, you know, cell-free DNA, circulating tumor cells. We're big into this. But we think new technology now, when you can work on small samples, again, the amount of material circulating in the blood reflecting your tumor for men with localized disease is minuscule. It's hard to pick out. But there's techniques now where you kind of suppress the background noise and can pick this out. A little different than men with advanced disease who have a higher burden of circulating DNA and other things. But I think, you know, again, we're excited by this.
Let me see if I can condense that a little bit, because there may be some men on this call that just have had a PSA and they're worried. They haven't even had a biopsy yet.
Yeah, so I tell those men, confirm get another PSA, be sure it's truly elevated. Are you at high risk? You have a strong family history, men of color, and you can go ahead and get a biopsy if you want, but we generally say instead of going right to a biopsy, do another marker, one of these serum, serum test, urine test, and if those are elevated, get an MRI and go an MRI guided biopsy.
Okay, well that's interesting. It sounds like you are suggesting then you do get this.
We do it. We now at UCSF we don't go right to a biopsy. We do these secondary markers.
Terrific.
MRI, and we do a targeted biopsy.
Yeah. Well, and I just wanted to say you said at UCSF that you're trying to get out of the biopsy business, and that's I haven't had a biopsy in 14 years. I refused a number of them along the way because I've been concerned about them. But how do the men on the phone call? You're on the leading edge. UCSF is on the leading edge. How do we follow what you're doing on your web?
I think few institutions have the volume that we do, but around the country, there are institutions regionally that are great institutions. You know, Seattle, Los Angeles, you know, UCLA, Northwestern, Hopkins, obviously, Vanderbilt. I mean, around the country, I'm sure I'm listening, you know, I'm leaving someone off, but around the country, this has gotten enough attention. So most places, Sloan Kettering is a major impact on surveillance. But you can find regionally providers. But I think in the community now, there's enough information out there that even community providers can offer the care that most men need. But, you know, shop around.
Dr. Carroll, you mentioned diet and exercise, and we've had a number of questions. First of all, about diet, and if you think it's specifically vegetarian or vegan diet is effective, but also other lifestyle changes like exercise and sleep and how they play, you know, and how effective they can be.
Yeah. So this is a testable hypothesis. So the impact of diet and exercise has gained traction over time. And I think there's evidence that it's certainly of complementary value. And again, the number one killer of men with prostate cancer is not prostate cancer, it's cardiovascular disease. So we don't need another excuse to live better lives. So I think we've actually seen that men who adopt a lifestyle change frequently, their sexual function improves. And so there's a lot of reasons that the good diet. You know, I did work with Dean Ornish. Hopefully he's not listening on the call here. We did work with his diet, which is a very rigid vegetarian diet. I think, you know, I think you can actually be very compliant without being too rigid. You know, life has got to be worth living. So I think that the information we have on the website strikes a nice balance. Again, I tell people, I think to a large extent, it's caloric intake. So avoid caloric intake, you know, eat less, avoid refined sugar, decrease consumption of red meat. I think fish, there's a lot of data that fish, if you can find some without mercury, may be of value. So I think a kind of a heart-healthy diet. Exercise, you know, work done by June Shannon, colleagues at UCSF, shows that diet does appear to have an impact, you know, these modulating these IGF levels. It turns out, you know, you don't have to run a marathon to get benefit from exercise. So the exercise requirements are actually relatively moderate. But we have exercise trials right now in early stage disease and advanced disease. So we're testing that hypothesis. But I think for many men, we have found that when they do something like exercise and diet, that they're more compliant. So I think Americans in general could eat better and exercise more. I can't comment on sleep because I'm a terrible sleeper. I'm one of these people who don't sleep a lot. In fact, I have to take my Garmin watch off because I'm too embarrassed to see, you know, because they uploads all my data online. I don't want to see how little I sleep. But I do exercise and I do eat well.
What about specifically herbal supplements and vitamins?
You know, everything. You know, I do. You know, nowadays with with COVID, this whole issue of vitamin D. So I do think there are things you want to do in general for maintenance of health. But in our experience, that a lifestyle modification is probably more impactful than any single supplement. Well, we've looked at single supplements. We don't see an effect. You know, I tell people I don't have strong feelings about one supplement versus another. I'd have them talk to their internist. But in general, we advise a comprehensive lifestyle change, diet and exercise, less so about single supplements. But in the information we have on our website, they talk about supplements.
Thank you.
I wanted to ask a quick question.
Mark, Mark, let me interrupt 1 second. I just want to, you know, we're running a little late and I just want to be sure that it's okay with Peter.
I'm okay, but you know, your audience, it's 9:30 for someone out there.
For all we know, the guy in Australia tuned in, so.
We'll check that. Just for a heads up, we have still 272 people on with us.
I'm good.
Well, why don't we go a little bit longer, Howard? I was just going to ask about the perineal biopsy versus the traditional biopsy and whether Peter had any suggestion.
Yeah, I do. You know, a transperineal biopsy compared to a transrectal biopsy is a little bit more diagnostic. But I think MRI targeted biopsies kind of level the playing field right now. So I don't think you need to go to a transperineal biopsy. Now, there are some situations we do. The patient I operated on today was a patient who had large prostate, had cryotherapy, failed. And on him, he had a transperineal biopsy to really map out his prostate because there was some discrepancy one side versus another. So there are a few situations where you do it, but I don't think you need to do it routinely. I think MRI is kind of level the playing field. When you do a biopsy, I think you get benefit from both the systematic biopsy and the MRI targeted biopsy. So the MR targeting and systematic biopsy add unique information both ways. But I think MRI is kind of leveling the playing field, and I think transperineal biopsy is going to become less common.
Thank you.
Can I follow up on that? What do you know anything about the precision point transperineal biopsy and if that's effective?
Well, I think any transperineal biopsy that's well targeted is a better biopsy in general, because remember what you're doing there is your biopsy is being taken in plane to the prostate, not at an angle, so it's in plane. So I think that the biopsies tend to be more diagnostic. Now, of course, they're not easy to do, and many people do them under anesthesia. So we do them rarely. We think an MRI guided, transrectal MRI guided biopsy, you know, with all the you can reduce the problem with the transrectal biopsy, which gets people concerned, is the infection rates. But our infection rate done by experienced providers is quite low. But there's a big worldwide controversy about transrectal biopsy and the risk of sepsis. And I think for men who, healthcare providers, men undergo repeated biopsy, men are exposed to a lot of antibiotics, are at risk of biopsy-associated infection. So those patients have to be careful about. But yeah, I mean, I think the key is that you can make many things more precise, but the key is, do they give you information that's better? So in my opinion, not all patients need a transperineal biopsy. And the other thing I worry about, the other thing I want to point out here is that I do worry about oversampling. So both with MR targeting and transperineal biopsy, you sample the prostate more. And if you have strict criteria about volume for surveillance, you could push a patient for surveillance who may not need it. So for instance, the criteria for less than 3 cores positive for surveillance, many people have that criteria. We don't, but if you go ahead and with MR targeting oversample the site, take 6 cores from sextant, you can oversample the prostate, so you can overestimate risk. So when you use new techniques, you have to be careful that they don't do the opposite, put you at risk by oversampling. So if you have strict volume criteria, then oversampling by transperineal biopsy or MR targeting could put patients who may be very good candidates for surveillance into a category that's not. So we're very careful. So if you take 2 cores from the target, you don't change the risk profile a lot. But if you oversample, take 4, 6, 8 cores from the target, you often get a higher volume. It's going to look like a higher volume tumor when it actually isn't.
Yeah, Peter, a couple of the people in the audience are asking for websites. One having to do with diet and exercise, or do you have a broader website address?
Yeah, so I would go, if you go to UCSF Urology, there's a patient information page. We have 2 booklets on that we produce with the Prostate Cancer Foundation, which I think are quite good. You can download the PDFs. Another site which I think is quite good is Prostate Cancer Foundation website. That American Cancer Society, I think there's a lot of them out there. There are books written on this. We're in the process of putting together a surveillance website, which kind of collects new information, new tools for patients. But I think if you go to our website, but most big centers have websites that have information on this, and Prostate Cancer Foundation, I think, is another good one.
Somebody asked here in the questions, is there anything outside the U.S. that's exciting you about active surveillance?
I don't want to insult anyone, but not that I know of. I think we have a great group of collaborators, in Rotterdam and around the world. The U.S., other than MRI, which is kind of we use worldwide, we compare our cohort to others. We see a little bit more. We see a lot more use of genomic testing in our cohorts. So there's nothing out there that I know of. But that doesn't mean there's not great work being done at other centers, and Rotterdam's one of them. But Milan, I mean, there's a lot of great people out there.
Although in some of the countries, like in Scandinavia, don't they actually have a higher active surveillance rate than we do?
Yeah, I know. So they have 80% plus. So that's the standard we think we need to get to. So there it's quite common, and they do it without the use of a lot of technology. But we think the number 80% resonates with us. So we think that's at UCSF right now in our surgical population, less than 8% of men are operated on with low risk disease, 6 to 8%. And usually those are men who are carrying genomic abnormalities or germline abnormalities. So we've we've gone from operating on low risk disease to operating on higher risk disease. We're a very busy surgical program, but we're not operating on men who don't benefit from it.
Okay.
Howard, there's some questions in the here. I don't know when you want to end, but people want to know where to get the slides, and you might want to let people know when
Yeah, well, we were going to summarize it later, but
I had a couple of I had a couple of questions. Maybe they're odd questions, but they've come up about biopsies specifically.
Yeah.
One is, can biopsies spread cancer?
Great question. I get asked this all the time. We actually looked at this. We don't think they spread cancer. So we've looked over time to see whether or not the biopsy is associated with metastases at all. And the answer is no. We've actually looked to see whether biopsy changes sexual function or urinary complaints. And actually no. But older men, of course, sexual function declines. So we're not seeing that the biopsy does that. But there's other reasons not to do a biopsy. But we think it doesn't spread cancer. You know, these are spring-loaded biopsy needles. I think when, in a way, 20, 30 years ago, they used these very large true-cut needles. Then you could see needle tract seeding, but we don't see that now. So I don't think it spreads cancer, but an unnecessary biopsy is an unnecessary biopsy.
Thank you.
Peter, earlier you had mentioned work going on at your hospital dealing with a vaccine. But what are your thoughts about Provenge?
I think
I'm assuming yours is
I think vaccines have to be much more tailored, much more powerful and tailored, and I think you're going to see that happen. I think they'll be able to. I think you'll be able to see the what I call the year of the bespoke vaccine.
You kind of broke up there. Could you repeat?
Yeah, so I think we need much more specific vaccines, what I call bespoke vaccines, tailored to your individual cancers. And I think that's what's going to happen. So you'll have vaccines that you'll be able to take biopsy material and put together a unique cocktail that's tailored towards your cancer. And not just a single antigen, but something's, it'll be a cocktail. It'll both be a vaccine and a promoter and other things. So I think the vaccines will become easier to make and much more specific. It's specific for your cancer. And work being done by Larry Fong and a group of, I'm working with a company as well that I think you're gonna see a lot. I think we're in the area where you see both biology and engineering collide in favorable ways. So you're gonna see the biological processes being done using engineering principles. It's gonna be remarkable. So I think when you see the intersection of both engineering and biology, you see something that's very translatable, that has throughput. And that's what's a remarkable, I think, a remarkable era we live in.
You talked earlier about MRIs. What will it take for MRIs to replace biopsies?
Now remember, an MRI can't replace a biopsy. So they've told you that if you need an MRI and something else. But let's say you have an elevated PSA and a normal MRI. If you don't biopsy that patient, they have an 8 to 15% chance, maybe a little bit higher, that they have higher grade disease. So what you do is you take the MRI and you use one other biomarker. PSA density works, 4K score, prostate health index. But a negative MRI does not guarantee you don't have high risk disease. So if you have a negative MRI, you want something else, another biomarker. Could be a low PSA density, could be a low a 4K score, prostate health index. The enthusiasm for MRI is kind of, in my opinion, outpaced some of the data. It's a great test. We've done over 20,000 scans here at UCSF. Endorectal MR imaging was developed here. But you need to, a couple things with MRI. One, it's not infallible. Two, there's considerable variation in reading. So you can have, even in one center, different physicians can read that MRI differently. So one thing we have to do is make it more accessible, less expensive, and we need to guarantee consistent and high quality interpretation.
Now, if you were to start over again with active surveillance and developing it, what would you do differently?
I don't think I would, but would have started earlier, so, but I did start early, but I maybe even earlier. I can look back in our path and feel good about it. Obviously, I've done thousands of prostatectomies. I'd like to take back all those prostatectomies I've done on men with low risk disease, early in my career. I'd like to take those back. Now I keep track record of my outcomes. So luckily, I think the outcomes have been good, but I think many men that we treated probably didn't need the operation. So maybe understanding this earlier.
I have a question specifically about 3+4 Gleason scores. Do you think that the protocols generally different for AS for men with 3-4?
Yeah, so most patients with 3-4 disease are not offered surveillance because they're considered intermediate risk. A couple things about 3-4. I think it's worthwhile, certainly if you have low volume pattern 4, to get your slides re-reviewed. There's a phenomenon called tangential sectioning. So that means when they put the biopsy in a little block of paraffin and they section it, sometimes they section it in a way tangentially that makes the 3-3 look like a 3-4. So certainly if you have low volume 3-4, you should have that slide re-reviewed. In general, we review all the slides to confirm the diagnosis, confirm the volume, confirm the grade. But certainly if you have a low volume 3-4, I would have that slide re-reviewed to be sure it's not this issue of tangential sectioning. So low volume 3-4 can be misinterpreted. 3-4 does carry a higher risk. So these are patients where I think MRI and genomics are very helpful.
And what constitutes high volume? That you mentioned volume.
Well, it's a problem, and I was on a conference call about this. It's difficult to put into practice because we look at millimeters, we look at total volume, we look at number of cores. But if you have more than one core involved, more than 50%, multiple cores, these are larger volume cancers. But I'm not saying you need to be treated, but you are at higher risk. And again, this is where I think technology like MRI and genomics helps. Probably these people at the edge of surveillance is where you can see whether or not they're behaving more like a low risk patient or a higher risk patient. So I think the 3-4 limited volume is a great group of people to do genomics and imaging on. I think MRI should be part of every MRI evaluation. I mean, of every surveillance evaluation. I'm seeing less resistance now, but I think MRI you can get almost anywhere. So I think maybe genomics could be challenging, but I think MRI is really essential.
Peter, I'm gonna have to go in a minute, but there's a question from Jim Schreit that we wanted to ask you. And you had that chart about the dramatic differences in active surveillance regionally.
Yeah.
And what can organizations like ANCAN, ASPI, all of us, what should we be doing to help fix that?
Yeah, I think the whole way the healthcare system operates now is different than 10 or 15 years now. Patients are becoming advocates for their outcomes. So I think the more information you get out to patients, especially patients who may not have access to high volume centers, would be important to let men know that they have options. And I think men and their families really drive remarkable differences in how we manage things. So the year of all of you, the year of advocacy over the last 10 to 20 years has been remarkable. So I think getting the message out there, getting data out there, I'm on, you'll get other people on, quality people. I think getting information out there, I think that empowers people. And I will continue to do what you're doing.
Well, listen, Peter, that's a good place to stop.
Okay, well, I want to thank everyone, and I will turn this over to you, but I want to thank everyone who's taken their time. If there's anything in addition I can do, Howard, Elliott, the rest of you, certainly let me know. Good night and stay safe. And wear your mask, social distance, wash your hands. Okay, bye now.
All right, I think I'm going to give a summary now of what we heard today. I mean, for me, the most important thing is is that there's someone out there working on an alternative to the biopsy. So many biopsies. I also want to give a heads up to our upcoming webinars, September 29th.
Keep going, Howard.
Keep going? I thought I was cut off.
No, you were not.
All right.
Oh, you're still on.
Okay, September 29th, we're having Dr. Brian Helfand to focus in on genetics and genomics and decision-making with active surveillance. On November 30th, we're having Dr. Antonio Westphalen of University of Washington to talk about many of these issues with MRI. On December 30th, we're having Dr. Jonathan Epstein, the Gleason grading guru from Johns Hopkins, to talk about critical issues of grading prostate cancer for patients considering active surveillance. I should mention the video and slides will be available at can.org. We'll also be sending out some sort of message to you all that'll give you the link where you can watch the video or share it with somebody else. I think that's about it. I turn it over to Rick.
Yeah, and I just thank everybody for attending. You'll find the information, the slides and the video if you go to the events on ancan.org, search for events or search for webinars, either one, it'll come up. You'll be able to download the slides. You will also be able to watch the video. We should get that video posted on there within the next few hours. And again, just an enormous thank you, not just to Dr. Carroll, but to all our ANCAN volunteers who have made this possible. I hope it's been a very useful presentation to those listening, and I hope you'll be back with us to listen to Dr. Helfand in September. So good night, everybody, and thank you very much.
See you in September.
Yeah, and everybody, we will send a follow-up email, which will give you all this information as well.
Okay.
So we survived, right?
Is the recording off, Joe?
No, it will be now, though.